We're moving on to our next speaker in this session, and it's Dr. Wes Ely, a leading internist, pulmonologist, and critical care physician. Dr. Ely is a professor at Vanderbilt University Medical Center, and he's also the co-director of the Critical Illness, Brain Dysfunction, and Survivorship Center. And Dr. Ely's groundbreaking research on ICU-acquired brain disease, particularly delirium, has led to a significant advancement in patient care and recovery. He's published extensively in top medical journals and is a passionate advocate for improving the quality of life for critically ill patients. And he will talk about the REVERSE-LC study that looks at immunomodulation as a pathway to discovery. So please welcome Dr. Wes Ely. Hi.
Fantastic. I want to thank everybody who's online today. We have a large group of people listening, and Amy's presentation was top-notch expertise. Amy, thank you for being a leader in this field. I understand you're going to have Dr. Akiko Iwasaki to follow me, so I'll be the low point in your morning after Drs. Proal and Iwasaki teach you so much about the disease state of long COVID. I want to start with a story. I recently have been taking care of a young man who has given us permission to learn from his story. He is a postgraduate student who was getting along quite well in life until he experienced acute COVID. And then about 6 months after having had acute COVID, he was scheduled to do a piano recital. He was a near concert pianist, and he was unable to move his left arm and unable to run anymore and having difficulty thinking. And this jumped forward 2 years into his postgraduate studies, has persisted and become an exacerbated situation with long COVID. He has well-documented long COVID. He is, as a grad student, sometimes finding himself in the classroom out of nowhere, just spontaneously bursting into diaphoresis, sweating, rapid heart rate, symptoms of POTS, dysautonomia, losing consciousness, going to the emergency department. Very distressing. This young man, extremely brave, moving on with his life, trying to move forward, and yet despondent and wondering, what does life hold for me? And in so doing, we join all of you who are suffering from long COVID. And I have no idea what you are going through, but I will say that we will not abandon you. We will not leave you. We will try and accompany you using the best that science has to offer to understand the right way forward with this disease state. I'm also on the National Academy of Medicine's Redefining Long COVID Committee, along with patients with lived experience who have long COVID. And all of us as scientists and those with lived experience are trying to do our best to put the literature together to come forward with the most appropriate clinical and research definitions for long COVID. And we are going to be referring to this as a disease state. That was something that we all felt incredibly passionate about, so that we can avoid any gaslighting, any movement within the medical community to disregard and to not take this as seriously as it needs to be taken. Clearly, we are dealing with a massive public health problem on the order of millions and millions of people around the world. And I'm here today charged with talking to you about one particular clinical trial, the RVLC, a reverse long COVID trial. So I'm going to do that now. I'm going to talk to you about a phase 3 NIH-sponsored clinical trial of immunomodulation in COVID, which we will be starting enrollment in several weeks. This summer, we will be actively enrolling patients into the reverse long COVID clinical trial. I am the PI along with Priscilla Hsu, who's at UCSF, and Vince Marconi, who's at Emory. That's a cardiologist and an HIV doctor. So there you have somebody involved specifically as a subspecialist with the heart. You've got an HIV doctor who's been studying JAK-STAT inhibitors for 10 years in another disease state that requires immunomodulation. And then myself as a physician scientist here at Vanderbilt University in Nashville, Tennessee. We'll also be enrolling under the leadership of Carolyn Bramante, who did the metformin study. You know about the metformin helping to prevent long COVID. She's at University of Minnesota. We're working with Dr. Akiko Iwasaki and her team at Yale, who will be scientists for their RVLC study, and also Mayan Levy, who is at Penn, who is studying tryptophan and serotonin metabolism through the butt-brain connection, to give you a smile this morning. And so all of these scientists, including Michael Peluso at UCSF, will be deeply involved in the RVLC study. How did this come to be? This is a circumstance where a computer, here's the story, okay? A computer in February, March of 2020, run by Justin Stebbing and colleagues using benevolent AI, artificial intelligence, was running through hundreds and hundreds of drugs to see which drug would work for acute COVID. In the Lancet, in the early spring, late winter, early spring of 2020, at the very beginning of the pandemic, in the Lancet, they published the results of the computer, the computer analysis, this artificial intelligence analysis, and the computer predicted that Baricitinib would be the best drug for COVID, acute COVID. We didn't even know that long COVID was a thing yet at this time. And so Vince Marconi and I worked as the co-PIs on the Cove Barrier study. We enrolled in 12 countries, 1,500 patients into the Cove Barrier study, Baricitinib versus placebo. And we had already had the data on steroids as improving survival in COVID. So we already had the data from the recovery study from England. And 85% of the people that we enrolled into our Cove Barrier study were already being treated with steroids. And when we added Baricitinib versus placebo on top of the steroids, Baricitinib provided the largest survival advantage, benefit of living rather than dying, over placebo of any drug yet in COVID era. And then Baricitinib went on to become the first immunomodulator approved for the treatment of acute COVID. Used all over the world in LMICs, lower middle income countries. Eli Lilly did a beautiful job of providing that drug free of charge to people in any lower middle income country around the world. The Partners in Health, the Paul Farmer organization, did a great job of working with Haiti and Dominican Republic and countries in sub-Saharan Africa, India, all over to do this, to allow people to be treated with this immunomodulator. And the World Health Organization included the drug, of course, as a high recommendation medication. Well, and by the way, I have no conflicts of interest with this medication financially. I have received not a single penny from Eli Lilly or any other industry group. I don't have any stock in the drug, in the companies that make this. We have been very, very diligent about not confusing our scientific inquiry, path of inquiry, with any potential financial benefit. So just for the listeners out there, we receive no financial benefit whatsoever. This is purely scientific investigation here. So anyway, after we went through the pandemic and the first, second, third waves occurred, we began understanding the depth and the tragedy of long COVID and said we should study the disease state of long COVID with this immunomodulator that works for acute COVID. And so we worked very hard to write a grant. This is the grant itself, the 500 pages of scientific pitch to the NIH, the National Institute of Health, and we're able to receive a 4th percentile score, which is a very good score, and they funded this investigation. So for the past year, we have been diligently building this investigation. We've got IRB approval. We've got the 4 sites for enrollment. We've got the 2 extra sites, Penn and Yale, to help us with additionally scientific inquiry. And this is not a low-touch study. It's a high-touch study. So here are the brass tacks. When we get the IRB approval for the website, late May, early June, the website will go live. Then we will start enrolling patients at the 4 medical centers in Minnesota, Nashville, Tennessee, Emory, Atlanta, and San Francisco, UCSF, California. And we will take patients from anywhere in the continental United States. I know there are many people from Europe who might want to get involved. We are interested in exploring European sites as well. When patients come to us, we will put them up in a hotel. We will pay for this service to provide them days as needed for the testing. As I said, it's not a low-touch study. This is not a do-it-at-a-distance study. We are going to fully investigate the disease state and the pathophysiology of long COVID in the context of this clinical trial. The 550 patients who enroll in this clinical trial will be reimbursed for their time and inconvenience, because we know it's a big gift of you and your love and your desire to improve this scientific situation to find cures for long COVID. And so the patients will be randomized into placebo versus baricitinib. The drugs they receive will be 6 months, one time a day of a pill to either get placebo or baricitinib. The patients will then be monitored monthly up to 6 months. They will then stop the drug. We'll be measuring all sorts of clinical outcomes. I'll get into that in a second. And then we'll follow you also for an additional 6 months so that we will get a year's worth of data, and then your involvement would be over. The patients who come into the investigation will be volunteering to have blood drawn, to get exercise, cardiopulmonary exercise testing, to get tilt table testing. They can opt into, but don't have to get lumbar punctures and MRIs of their head. The primary objective in this investigation is to see if the brain fog, the neuropsychological impairment that is present in so many patients with long COVID, will improve. We are interested in understanding, in other words, if immunomodulation with a JAK-STAT inhibitor, the same drug that saved the lives of so many people in acute COVID, will improve the lives of people who have long COVID. Now, I'm not going to share it, but on my desk, I've got the mechanisms of baricitinib. I'm just going to run through. This is an antiviral. It's an immunomodulator. It works to help with persistent cytokine release, immune activation. We're talking about interleukins. We're talking about TNF, soluble TNF, CCL7. Many interferons are affected by baricitinib. And so by multiple attack on the immune system in terms of immunomodulation, this is not as much an immunosuppressant as it is an immunomodulator. For those who don't know the drug baricitinib, this is a drug that's already taken safely for years and FDA approved for diseases like rheumatoid arthritis, lupus, alopecia areata, atopic dermatitis. So other sorts of immune-mediated autoimmune diseases have been proven and published in the New England Journal of Medicine and many other journals to be modified in a good way by this circumstance. It may be that the immune dysregulation that occurs in long COVID will be calmed down by this daily receipt of baricitinib for 6 months. It's as if, think of this like this way, it's as if a light switch was turned on by the acute viral infection of COVID, and somehow we, all of us, Akiko Iwasaki, Amy Proal, all of us as scientific investigators, are trying to figure out what's the safest way to allow us to turn off that light switch without injuring people in the process. And for me, as a clinical investigator, I only pursue investigations if they meet both of my clinical rules for research. That means that they have to, either answer has to be important, and we only study what we have a lot of. We have millions of people with long COVID, and it doesn't matter what we see here with baricitinib because either answer is going to tell us an immense amount about the disease state of long COVID. Now, like you, I am absolutely hopeful that just like baricitinib improved survival in acute COVID, that it will also improve survivorship in long COVID, and that we will see an improvement in cognition, an improvement in blood pressure and heart rate stabilization, an improvement in gastrointestinal disturbances and in dysautonomia. These are the things we're hoping will happen, but we have to have equipoise, and we don't know if this immunomodulator will do that or not. Yet, if it doesn't, it will be extremely important to the science of long COVID to understand what we then need to go to next. In the future, we also hope to be studying a second study called RVLC-MET, which is RVLC using metformin. We're going to follow up on Carol Bermonte's original investigation. And so there's lots of ways that we will be pursuing the science of immunomodulation in long COVID. RVLC is the first step. We realize the time crunch, and we are going to do this as quickly as we can. I'm going to stop and take any questions you might have now. I realize I might be stopping a little bit early, but I want to give you time for questions. And that's basically the story. Thank you so much, Stefan and group, for having me today. Again, my name is Dr. Wes Ely. I'm a physician scientist at Vanderbilt University, and you can find us on our website at icudelirium.org because I have studied for the past 30 years the problems of acute brain dysfunction in acute illnesses and in survivorship. And that's what we've been doing for 30 years. And now we've just pivoted to make our research lab, 120 people here at Vanderbilt University, now devoted to understanding the disease state of long COVID. And that's what we're hoping to do, is provide some help and some answers. Thank you so much for your time and attention today. And I'd be happy to open it up for questions. If somebody wants to go through the chat and read them to me, I'm all yours.
Wow, thanks a lot for that enlightening presentation and the storytelling behind it. You teased it as a low point. It sure didn't feel like a low point to me. But we have now definitely a lot of questions for you. And you mentioned the light switch, right? So you switch on the immune system, and you're trying to switch it off in a safe way. And the question is there a tipping point in the immune system where long COVID or ME/CFS cannot be cured anymore? So the switch doesn't turn off anymore, maybe?
Well, I love your question. And I believe as a physician scientist that we need to answer your question. And because of that, in RVLC, we are not going to only take people with recent long COVID. In fact, 2 criteria for the study. One would be that we're taking people who have symptomatology for 6 months or more. And but the overall definition is 3 months or more. I realize that, but we want people who aren't going to be getting better within 3 to 6 months. So we're taking them after 6 months of symptomatology. They will have to provide proof of acute COVID. Other than, we're going to take people from the first wave who don't even have a positive COVID test because they got their COVID and long COVID prior to the advent of the COVID test. So we will be one of the first investigations, and hopefully others will follow suit, to take people from the first wave who don't have the ability to prove that they had acute COVID on the front end. And we thought this was a very important thing to do for inclusion and equity across the long COVID community. I hope that you agree. And because of that, you can see that we're going to have people who have had 3 years of long COVID. And we're going to enroll them in the study, and hopefully we'll be able to use subgroup analyses to see if there is a differential effect of Baricitinib in people who had 3 years versus perhaps 1 year of long COVID. Great question.
Okay, wow, thanks for that. When you deal with the immune system and you switch the immune system off, maybe switch it more off than before because of the immunomodulation. What about the increase of viral replication? Amy Prowl talked about viral persistence. If you switch off the immune system, at least part of it, what happens then? Yeah.
Sure. Yeah, we will absolutely be monitoring. Your question is appropriate from a safety perspective. It could be that a drug like Baricitinib or any immunomodulator, some of the ones that Dr. Prowl was speaking of as well, it could be that we see an increase in viral replication. We actually want to bring up the opposite possibility. It could be that Baricitinib, by modifying the immune system in a good way, turns off the dysregulation and allows the body to actually do a better job of handling the ongoing viral replication in the body that is creating this ongoing antigenic stimulation. It is true that patients who have RA, rheumatoid arthritis, lupus, alopecia areata, atopic dermatitis, these immune-mediated disorders, it is true that they take this drug safely and do not have a rampant problem with opportunistic infections such as people have when they're profoundly immunosuppressed after chemotherapy. It's also the case that we will be monitoring for viral replication. So for EBV, for COVID itself, HSV, et cetera, we will be absolutely monitoring all of the patients in RVLC to know which one of these 2 things happens.
Okay, great. And as you mentioned, there's a lot of data on JAK-STAT inhibitors already, and other pathogens could have reactivated before, right? So are you familiar with Rob Fair's interconnect shunt hypothesis? He suggested that JAK-STAT inhibitors could break the chronic shunt.
Yes, I'm absolutely familiar with the shunt hypothesis. I think it's a brilliant scientific idea. And this is the sort of scientific hypothesis that I think is worthy of testing. And the best way to test such a hypothesis is through a double-blind, placebo-controlled study. There are lots of other ways to test things. You can look backwards at cohort studies, et cetera. But the RVLC, what we're doing here is we're trying to bring the most robust science into the game to understand whether or not these hypotheses are true. And as I said earlier, I have equipoise. Either answer matters here. And each patient who gives of himself or herself, themselves, to be a part of this investigation will be joining the rest of humanity to try and help one another find scientific answers. It really is about mercy. We are bringing mercy into the situation of long COVID and ME/CFS, because mercy is my willingness to dive into the chaos of another person's life and provide lifting and healing. In fact, I'm about to go speak about this. I have this book, Every Deep Drawn Breath. I'm not advertising to make any money. All the money from the patients' lives in Every Deep Drawn Breath goes into our survivorship program. Every penny goes in for long COVID patients and families. And we have a social worker that we've hired from Every Deep Drawn Breath's endowment. And that social worker sits outside my office every day and spends the entire day helping long COVID patients and their families find jobs, disability programs, help them avoid self-harm, and housing. So we believe that RVLC is part of an overall project of humanism to try and bring the level of human dignity and elevate it for all of you who are suffering from long COVID. And it would be inappropriate for me to talk to you only about the science when so much of what we're doing is about the humanity.
Yeah, great, great. And it brings back memories to the opening ceremony and the talk of Ed Yong, who also mentioned this is a task for humanity to solve and not only for science. Wow. I wish that all professionals please include in all studies, trials, and treatments also a post-vaccination syndrome besides LC, post-COVID, and ME/CFS and other post-infection syndromes, because we need to support. Is this study appropriate for Baricitinib, or is there any plan to include?
Yeah, I am an absolute believer of and want to support your statement. Post-vaccine syndrome is real. It mimics oftentimes and looks extremely like long COVID. It's a travesty for those people who have this. We have patients in our CIBS Center long COVID support group. We have support groups every day here of patients, families, et cetera. And we absolutely have people here who are suffering from post-vaccine syndrome. Each study has to have its focus. So this study is about long COVID from the virus, but we absolutely anticipate in the future enrolling patients with post-vaccine syndrome into clinical trials to do this. And while this particular NIH study was funded to study the concept of long COVID after the virus itself, you have a space in the science, and you must be included in prospective randomized controlled trials going forward. The challenge, of course, is getting enough people, but I believe we can do this if we work together. And so I am on your same team, and I support what you said, what you just said, and we want to find answers for your population as well.
Thanks a lot for this. Is CAR T cell therapy a possible therapy option in the future? So a different angle, different approach, but also addressing the immune system.
I think it absolutely is. I just read a paper in the New England Journal of Medicine, I believe, on CAR T therapy solving an autoimmune disease. And this is where we're taking CAR T and going beyond malignancies into immunomodulation. I've had many patients who have CAR T therapy. It's not without its set of severe risks. I'm an ICU doctor. Just last week, I had several patients in my ICU suffering from CAR T immune-mediated diseases. So this is, as my resident said last week when we were admitting a patient, she said, CAR T is no joke. And I was like, no, it is absolutely no joke. So it's a very, very intense thing to do to the human body. And also, yes, I believe it is on the table to investigate for diseases like long COVID.
Yeah, but it might not be the safest way to switch off the light. From your perspective, is interferon therapy alone a promising way to treat long COVID, or at least specific cases of long COVID accompanied by latent virus reactivation?
It's a really good question for Akiko Iwasaki, who's going to be speaking next. So bring that back up to her. I don't think she's on yet, but I think it's on the table. Although interferon therapy did not, it had very mixed results in acute COVID. Will it work for a long COVID or not? No one knows the answer to that. As I was saying earlier, you've got a drug in Baricitinib, which absolutely affects interferon gamma and numerous other aspects of the immune system which have gone awry. So Bari is a medication which could be an interferon modulator, which is an interferon modulator. It's just that it does a lot beyond just that one silver bullet. So I personally believe that we're going to have to go broader, but I absolutely know that we should go as narrow as we can go. So the study that Amy Proal talked about starting in California at UCSF, which is going to be a narrower form of immunomodulation, must happen. We have to approach this from multiple prongs to know which is the safest way to turn off the light switch.
Yeah. Thanks. Will you also include those almost the exact same sequelae described as post-COVID vaccines? Or we had that question already.
Yeah, that's true. Yes, we will.
So moving on, how do you rule out viral persistence or ongoing viral replication? Or we had that question as well.
Yeah, we'll be checking all that.
Yeah, when metformin is helpful, is there a possibility that inositol, which is some sort of natural version of this regarding insulin resistance, might be helpful as well?
Yeah, we could do that. I want to study metformin first because we at least have proof of principle already that metformin, when given to patients with acute COVID, reduces the acquisition of long COVID. So that's, to me, a great next step, and that's why our second study is going to be of metformin. And then if that works, then we move on to other things that I'll call kissing cousins.
Okay. What do you think about treating ME/CFS with monoclonal antibodies? Why isn't there more research studies regarding that? So another question.
I think that anything that's on the table to study for long COVID should also be investigated in ME/CFS. And we will absolutely be using ME/CFS questionnaires in the context of RVLC. So we will know if our RVLC participants have the constellation of symptoms and signs and symptoms of ME/CFS and what happens to them when they receive Baricitinib. Likewise, that should also be done, similar programs should be done for any of the other immunomodulators, whether they be narrow or broad.
Yeah. But depending on the cause of ME/CFS, you would need different antibodies because some are COVID-derived and others might be different pathogens involved, right? What about seriously compromised patients who cannot travel such a distance? You mentioned the study is quite intense. How do they might get involved into the study?
Well, this is a limitation. We know. I have people I know personally and who have we've been involved with through our research center who are bedbound, and that will be a very difficult person to be able to participate in this particular investigation. However, there are many other investigations coming online, many of which are low touch, and I think for those patients, the low touch studies are probably going to be the most allowable for their lifestyle and life situation. I'm willing to work with anyone if they really want to be in RVLC to see how we can accommodate. And at the same time, I want to be extremely sensitive to and careful with their health. So in other words, coming to a research center from far away when you're that ill and bedbound, I think could be an extremely dangerous thing to have happen in your life. And so while I'm open to discussing it with them, they ultimately have to make their own risk-benefit decisions about involvement in these clinical trials. It's up to, they are the final, they and their loved ones are the final deciders about whether or not they can and should take part in which particular clinical trial.
Yeah. Thanks a lot. Time is flying. We covered a lot of questions, but sure, we didn't cover all of them. So we are now, unfortunately, at the end of our schedule. We greatly appreciate your inspiring insight and hope to hear back from your study anytime soon.
Thank you for having me. Appreciate you.